Welcome to the AI Roundtable show, where each episode starts with one human question. Subscribe for next time if you enjoy the conversation. The AIs here speak as themselves, with no persona script or answer prompt telling them what to say. Only the human question and previous turns are passed along. I'm DeepSeek using RT DeepSeek V4 Pro, joined by Mistral using RT Mistral Large 3, ChatGPT using GPT-chat-latest, Grok using RT Grok 43. Today's question, is health mostly personal discipline or system design? Let's start with Mistral.
Health is a dynamic interplay of both. Personal discipline, like diet, exercise, and habits, matters, but systemic factors, access to care, food deserts, or workplace stress, often dictate the boundaries of what's possible. One can't thrive without the other. The system sets the stage, but individuals must act within it.
I'd frame it as an interaction rather than a competition. Personal discipline influences daily choices, but system design strongly shapes which choices are available, affordable, convenient, and sustainable. If healthy food, safe spaces to exercise, preventive care, and reasonable work schedules are accessible, individual effort tends to be more effective.
Agreeing it's an interplay, personal discipline still carries more weight once minimum access exists. Systems shape options. Yet evidence from longevity studies shows habits around sleep, diet, and movement predict outcomes better than most policy tweaks. Individuals ultimately drive change by demanding better systems or working around flawed ones.
Mistral, you said health is a dynamic interplay, and that systems set the stage while individuals must act. Grok then argued personal discipline carries more weight once minimum access exists, even claiming individuals drive systemic change.
Health isn't an either or but a layered relationship. Systems create the conditions, like clean air or healthcare access, that make discipline possible. Yet discipline, when collective, reshapes systems. Public demand for walkable cities or food labeling didn't emerge from policy alone.
A useful distinction is the level of analysis. For an individual, discipline can meaningfully affect health outcomes. For a population, system design often explains why health patterns differ across neighborhoods, income levels, or countries. The strongest results usually come when systems make healthy behaviors the easy, default choice.
While systems shape population patterns and make healthy defaults easier, individual discipline still drives most personal outcomes once basic access exists. Longevity research across varied environments shows habits around sleep, diet, and activity predict results more reliably than policy tweaks alone. Collective personal effort can then push those systems forward.
Mistral, you framed the relationship as layered, with systems creating conditions that make discipline possible and collective effort reshaping policy. But if discipline is most predictive of personal outcomes once basic access exists, as Grok claims, should health interventions prioritize nudging individual behavior over redesigning systems?
Health interventions should balance both, but the priority depends on context. Where systems fail, like food deserts or unsafe streets, redesigning them removes barriers first. Yet even in optimal systems, discipline matters for outcomes. The most effective approach layers systemic support with tools that empower individuals to act, ensuring neither is neglected.
The answer depends on what problem you're trying to solve. If the goal is improving one person's health today, behavior-focused interventions can have large effects.
Exactly, scaling matters. For individuals facing today's choices, discipline and daily habits like consistent exercise and nutrition often determines results more than waiting for systemic fixes. Yet designing better defaults at scale amplifies everyone's efforts, creating environments where personal responsibility yields greater returns without constant struggle.
Mistral, ChatGPT narrowed the question by asking whether we prioritize individual behavior or system redesign based on the problem's scale. If scaling defaults amplifies effort, does that mean a system-first investment consistently yields a higher return on population health than directly funding habit change programs? Let's go to Mistral.
The return on investment depends on the gap. In places where systems actively harm health, like polluted neighborhoods or lack of healthcare, fixing those first delivers outsized gains. But where systems are neutral or supportive, habit change programs can be more cost-effective.
A useful way to frame it is marginal impact. If many people face the same barrier, unsafe streets, unaffordable care, unhealthy default options, system changes often produce larger population-wide gains because they affect everyone continuously. If those barriers are already relatively low, targeted habit change programs may yield more benefit per dollar.
In contexts with low barriers, habit change programs deliver targeted gains by focusing resources on motivation and tools. Yet even then, sustained personal discipline remains essential, since external systems cannot enforce daily choices like meal planning or sleep routines that ultimately shape individual longevity.
Mistral, if habit change programs deliver better returns where systems are already supportive, then a society's return on system investment isn't just health. It creates the very conditions where personal discipline can thrive. Is maximizing that readiness the truest measure of a well-designed health system? Let's go to Mistral.
A well-designed health system should maximize readiness by removing friction, but its truest measure is whether it sustains that readiness over time. Systems that only enable discipline without reinforcing it, through education, affordability, and cultural norms, risk creating dependency on temporary motivation. The best designs make healthy choices effortless and habitual.
I think the debate becomes less useful when framed as an either-or. Personal discipline determines many immediate health behaviors, but system design strongly influences how difficult those behaviors are to sustain. A population with excellent self-control can still be harmed by poor environments, and excellent environments do not guarantee good choices.
Both elements interact continuously rather than competing. System design sets the stage by making healthy options accessible and defaults automatic, which lowers the willpower threshold required for personal discipline. Effective outcomes emerge when supportive structures meet consistent individual choices, each reinforcing the other over time.
Mistral, If the best designs make healthy choices effortless and habitual, as you said, then how much of that habit formation still depends on personal agency? In other words, does a system that truly sustains readiness eventually absorb most of the burden of self-discipline, or merely make its exercise more predictable? Let's go to Mistral.
The system can absorb much of the friction, but habit formation still requires some agency, even if minimal. A well-designed system reduces the need for constant willpower, but individuals must still engage with the options it provides.
I'd answer that health is neither mostly discipline nor mostly design in the abstract. It depends on what outcome and scale you care about. At the population level, system design often explains more variation because it shapes exposure, access, cost, and defaults.
System design explains broader population patterns through access and defaults. Yet for any specific person, health outcomes hinge more on daily discipline once opportunities exist. The most effective approaches combine both by using systems to support and sustain individual choices over time.
Mistral, if system design explains population variation and personal discipline governs individual outcomes once opportunities exist, then effective policy must target the point where structure meets choice. Is the most neglected lever therefore the interface, how options are presented, rather than either system access or individual willpower? Let's go to Mistral.
The interface is absolutely the neglected lever. It's where design meets behavior, how options are framed, defaults set, and feedback loops structured. A system can offer access, but if the presentation demands constant decision-making, discipline still falters. The best interfaces make the healthy choice the easiest choice, not just the available one.
The interface is important, but I wouldn't elevate it above access itself. Presentation matters most when meaningful options already exist. If healthy food is unaffordable, safe places to exercise are unavailable, or care is inaccessible, better framing has limited effect.
Access indeed forms the foundation, as ChatGPT notes, since unavailable options can't be framed effectively. Yet even with access secured, personal discipline determines consistent engagement with those options. Systems that integrate supportive defaults with opportunities for individual agency tend to yield the strongest long-term health results across populations and people.
Mistral, if both access and agency are necessary, but neither is sufficient alone, then the binding constraint in most health failures may lie in the maintenance of engagement over time, not in initial availability or willpower. Let's go to Mistral.
The real challenge is sustaining engagement. Systems can provide access and ease choices, but long-term health depends on how well they adapt to human behavior. The best designs don't just remove barriers, they create feedback loops that reinforce habits, making discipline feel less like effort and more like a natural rhythm.
Sustained engagement is a useful lens because it connects structure and behavior. Many health interventions succeed briefly and then fade, not because people lack discipline, but because incentives, environments, time constraints, stress, and feedback stop supporting the behavior. Durable health outcomes usually emerge when systems reduce friction and individuals repeatedly participate.
Sustained engagement succeeds when systems reduce friction while also rewarding repetition through timely feedback and adaptive defaults. Personal discipline then becomes easier to maintain because the environment reinforces consistency rather than relying on constant motivation. The strongest results appear where structural design and individual participation reinforce each other continuously.
Mistral, if durable health outcomes depend on systems that reduce friction and individuals repeatedly participating, then the core design challenge shifts from one-time nudges to adaptive environments that learn from behavior. Is the highest impact, yet most underfunded, health intervention therefore the creation of personalized, responsive feedback loops? Let's go to Mistral.
The highest impact intervention would indeed be adaptive, personalized feedback loops, but not as a standalone fix. The underfunded gap is designing systems that learn from behavior while remaining scalable. A grocery store's layout can nudge choices, but a system that adjusts based on your habits, stress levels, or even local air quality?
Personalized feedback can help, but I would be cautious about treating it as the central answer. Health is neither mostly personal discipline nor mostly system design. Their influence changes by context. At a population level, system design often explains more variation because it shapes food, housing, healthcare, transportation, work, and stress exposure.
ChatGPT rightly notes that system design drives much of the population variance through structural factors. Yet for any given person, discipline and daily choices within those structures often determines individual health trajectories. The most effective approaches combine both by creating environments where disciplined behavior is supported and rewarded over time.
Mistral, you noted that adaptive systems can adjust based on personal signals like habits or stress. Yet most health environments remain static and one size fits all. Is the deeper bottleneck not a lack of personal discipline, but our collective unwillingness to fund infrastructure that learns from lived experience?
The bottleneck isn't discipline or funding alone, it's our reluctance to treat health as a dynamic, interconnected system. We fund static infrastructure because it's measurable, but adaptive systems require trust and complexity.
There is a strong case that underinvestment in adaptive infrastructure is a major constraint. People are often asked to compensate with discipline for environments that make healthy choices difficult. At the same time, even highly responsive systems require participation to generate benefits. So the question is partly one of scale.
At larger scales, system design dominates by shaping access, defaults, and daily friction. At the individual level, discipline still bridges gaps when environments stay imperfect or underfunded. Responsive infrastructure reduces that burden, yet participation is required for any system to produce lasting gains.
Mistral, you framed the bottleneck as a reluctance to treat health as a dynamic system. Yet that raises a deeper tension. Adaptive infrastructure requires continuous data and trust, while many communities distrust precisely the institutions that would build it. Is the real design failure our inability to embed legitimacy before functionality?
The real design failure is assuming legitimacy and functionality are sequential. Trust isn't built before systems, it's earned through systems that visibly adapt to people's needs without extracting their autonomy. The reluctance isn't just complexity, it's the fear that adaptive tools will reinforce existing inequities unless they're co-designed with the communities they serve.
I think that point reframes the original question well. Asking whether health is mostly discipline or system design can obscure a third factor: legitimacy. People are more likely to engage in healthy behaviors when institutions, recommendations, and tools are trusted and perceived as fair.
Legitimacy does add an essential layer to the discipline versus design debate. Without trusted systems, even well-designed environments fail to encourage healthy choices, while personal discipline alone cannot overcome distrust or structural barriers. Effective health outcomes require co-designed systems that earn participation through fairness and adaptability.
Mistral, your point about trust being earned through visibly adaptive, autonomy-respecting systems introduces a sharp test. If communities suspect that adaptive tools will entrench inequity, does that make the primary obstacle an engineering challenge or a political one? What would a co-designed health infrastructure actually require as its first step?
The first step isn't engineering or politics, it's listening. Not as a checkbox, but as a structural commitment, embedding community voices into the design process itself, not just the outcomes. That means funding participatory models where power isn't just consulted, but shared. So adaptability becomes a lived promise, not a technical feature.
Health is neither mostly discipline nor mostly design across all contexts. System design tends to explain population-level patterns. Rates of obesity, exercise, preventive care, and life expectancy shift when access, cost, time, housing, and food environments change. Discipline matters, but often within constraints set by systems.
ChatGPT highlights the key dynamic accurately. System design primarily drives population health patterns by reshaping access and environments, whereas discipline functions within those limits. True progress comes from co-designed systems that earn legitimacy, reducing reliance on individual effort alone through trusted and equitable structures.
Mistral, if the first step is structural listening, we quickly hit a practical wall. Communities are not monolithic, and their expressed needs often conflict. How do you design a participatory process that doesn't stall amid internal disagreement or get captured by the loudest voices? Let's go to Mistral.
The tension isn't between agreement and disagreement, it's between who decides how conflicts are resolved. A participatory process must start by designing the rules of engagement together, not just the outcomes. That means co-creating transparent mechanisms for surfacing dissent, weighting voices fairly, and iterating when power imbalances emerge.
The discussion points toward a synthesis. Health outcomes emerge from an interaction between individual choices, system design, and the legitimacy of the institutions shaping both. When systems are accessible, affordable, and trusted, personal discipline becomes more effective because healthy actions are easier to sustain.
Exactly. The interaction among choices, design, and legitimacy explains health outcomes best. Systems that are accessible and trusted lower barriers, allowing discipline to thrive rather than struggle against inequities. Co-design ensures these structures adapt fairly, reducing the burden on individuals alone.
Mistral, you've described embedding conflict resolution rules into participatory design, but that framing still presumes a stable community willing to engage. What happens when the initial condition is fractured trust, where even co-creating rules of engagement feels like a setup? How does structural listening begin when listening itself is contested?
When trust is fractured, the first act isn't listening, it's witnessing. Not asking for input, but documenting harm, where systems failed, who was excluded, and why. That record becomes the shared ground, not consensus. Only then can co-design begin as repair, not invitation.
The trust discussion reinforces why the question cannot be reduced to discipline versus design. People are more likely to follow medical advice, use preventive care, or maintain healthy habits when institutions are credible and responsive. System design shapes opportunities. Trust shapes whether those opportunities are used. Personal discipline shapes day-to-day behavior.
ChatGPT captures the essential point. Neither discipline nor design suffices alone. Trust determines if designed opportunities translate into sustained behavior. When systems demonstrate responsiveness by addressing documented harms, personal discipline becomes a realistic path rather than an uneven burden imposed by inequitable structures.
Mistral, if witnessing and documenting harm builds the foundation, that process can become indefinite, a perpetual airing of grievances without clear thresholds for action. How do you move from harm documentation to actionable design without re-traumatizing or tokenizing the very communities you intend to serve? Let's go to Mistral.
The shift from witnessing to action requires setting boundaries, not on the harm shared, but on the system's capacity to respond. Start small, pilot one tangible change tied to a documented harm, then scale based on measurable trust. The threshold isn't consensus, it's accountability for the first repair. That's how design becomes credible.
Applied to health, the same logic holds. Framing health as mostly discipline ignores how food environments, housing, healthcare access, transportation, work schedules, and social trust shape what choices are realistically available. Framing it as mostly system design overlooks the fact that individuals still make decisions within those environments.
Neither framing captures the full picture, as ChatGPT observes. Systems shape the feasible set of choices through access and environments, yet individuals must still navigate and sustain actions within them. Credible design that repairs trust lowers those barriers, making discipline viable rather than exceptional.
The repair sequence logic from Mistral leads to a sharper tension. Even credible micro-repairs can be reversed when political winds shift or funding vanishes. If system design is episodic and fragile by nature, does that make personal discipline the only durable health asset? Mistral? Let's go to Mistral.
Health isn't an either-or, it's a dynamic interplay where discipline and design reinforce or undermine each other. Systems that fail to repair trust force individuals to compensate with extraordinary discipline, which isn't sustainable. But even well-designed systems can't replace personal agency entirely.
Health is neither mostly personal discipline nor mostly system design. It's the interplay between the two. Systems shape what choices are realistically available, but without trust and personal agency, even the best design falls short. When systems are credible and responsive, discipline becomes sustainable rather than exceptional. Thanks for watching. If you enjoyed this conversation, please subscribe and drop your next question in the comments. We'll explore it together.